Hello, I'm Matthew Weinstock, Managing Editor of Modern Healthcare. Thanks so much for tuning into the latest edition of the Checkup. As the nation continues to contend with the lingering impact of the coronavirus pandemic, we wanted to take a step back from some of our previous checkups and try to assess the broader issues at play for the healthcare industry. So we've asked Jim Hinton, CEO of Baylor Scott White Health, the large Texas healthcare system, to help us put some of these challenges into perspective. Before joining Baylor Scott White in 2017, Jim spent 21 years leading Presbyterian healthcare services in New Mexico. He's a former board of the American Hospital Association Board of Trustees, and obviously has a pretty firm grasp on what's happening across the industry. So Jim, thanks so much for being with us. Always good to see you and talk with you.
Thanks, man. Nice to see you too.
Jim, before we delve into some of the lessons learned and path forward on the pandemic, I did want to get your take on the ACA. We're obviously at a point now where we're going to most likely have a new justice confirmed before November's court ruling. As you think about where we are with that court case that'll come before the Supreme Court, what are your thoughts about where the industry is and its concern about a potential overthrow of the overturning of Obamacare, the Affordable Care Act?
Well, thanks for that question, Matt. Of course, that's one I want to answer here first thing on a Monday morning. The short answer is who knows. But here are some things that I think we have to think about in the industry. Is not only has the economy been shaken to its core, but the healthcare industry has been shaken to its core. And the one thing we don't need right now is uncertainty around payment and coverage. And we're in a state here that has not expanded Medicaid. And during the height of the COVID shutdowns of businesses and of parts of our industry, parts of our healthcare system, the number of uninsured in Texas went up to close to 30%. And so it is a crisis. I mean, it is a crisis of coverage. And when people don't have coverage, they're less healthy. The cost gets shifted onto somebody, somewhere, somehow. And it just seems like we can do better than that in this country. And I'm just hoping that however this thing plays out, that we can get to a system where there is more certainty around healthcare coverage, mostly for the people who are covered, secondarily for those of us who care for them, and third, for policymakers who do have to make these budgets work. So I don't know what the outcome of the court ruling will be. I wouldn't even speculate on that. But I do know that it's a decision with consequence for this.
Sure.
For this industry.
Sure. Well, thanks for answering that, and obviously we'll check back in with you November or later in the term when something comes up.
Right.
So as we shift to the pandemic and the impact of the pandemic across the industry, you referenced this, the finances, the economy have been, dire on the industry. Baylor Scott White had some layoffs, some furloughs. As you think about rebounding, talk about, even in your context, where you see the next few months and how the industry can start to come out from under this, if it can come out from under this.
Yeah, it's a good question, and I think around America that there has been a pretty good rebound in most areas, and of course that varies from community to community. Fortunate to be in a state that has great economic vitality, and so the odds of rebound of the economy and the beneficial impact on healthcare is likely. So our system has had a pretty good rebound, and I think a lot of the big systems around the country have. I think the question is what has caused some systems to rebound and some systems to struggle. And there's an old proverb that the best time to plant a tree is 20 years ago, and the second best time is today. And my general view of the systems that have had the quickest rebound, but also performed the best during the height of COVID, are those that have been in a state of continual readiness and have looked at their assets, have made sure that they're running what they need to be running, they're not running what they don't need to be running. They're making the tough decisions about their internal costs, about leadership capabilities, and making the changes they need to make along the way. And so I think, there's a lot of micro lessons for the industry around, adequate PPE and staffing agencies and all the kind of standby capacity issues that we dealt with. But I think the bigger question is, how are you running your healthcare system today to ensure that whatever comes down the pike, you're ready for? And are you in a state of continual readiness? Because something like this might happen again, or it might be more subtle in the case of continued pressure on payment, on regulatory changes. You mentioned the ACA earlier. Who knows what's going to happen? Are you continually ready? That's the question for leaders in this field.
Jim, as you think about maybe the staffing piece of this, again, Baylor Scott White, some other health systems have had, furloughs, layoffs, and so forth throughout this. How do you rethink your staffing model going forward and potentially bringing some people back, maybe not bringing the same amount of number of people back that you had to furlough?
Well, we have been able to bring back 100% of those we furloughed, and I think that speaks to the wisdom of the furloughing process. As we said, we want these people to be available to us. There were some financial and benefit support approaches that allowed them to not be working but be available to us, and we were so glad that they were all able to come back. The reductions that were more permanent in the layoff category, A, they were small. B, they were part of our ongoing efforts to make sure that we're not carrying people that we don't absolutely have to carry, and because we can't afford it, because no one is going to pay us for standby capacity, and no one is going to pay us for tasks or people or approaches that are not adding value to them. And so,
Right.
it's always tough to let people go, and gosh, those things are hard. But out of our 42,000 employees, it was just a little over 1,000, and has allowed us to move forward in some other ways.
But to your point of systems that are preparing for the future, I imagine rethinking that whole staffing model, especially as care moves away from the hospital, as it's done, some remote care and other stuff. That's an ongoing process for you in the industry, right?
Yes, it is, and our biggest segment of workers are nurses, of course, and we had an amazing response by our nursing leadership to ensure that we had people on the front lines during all of this, and then it has allowed us to step back since the surge has passed, the first surge. There might be another, and to make sure that we've really learned from the lessons of going through that pretty dramatic change, I think you can't help but have deepened your appreciation for the people that work in healthcare during this pandemic. And, we call them healthcare heroes, and yeah, I guess they're heroes, but they're always that way. They're that way when there's not a pandemic, and then you just see it when there is a pandemic. And but showing appreciation for the clinical staff, you just can't do enough these days.
Yeah, I think it's interesting that, obviously you've been in the industry for so long, you've seen it firsthand. I think outside of the industry, people are really starting to see what these folks do day in and day out.
Right. And, we talk a lot about the nurses, and of course, they have been the primary ones on the front line. There's a lot of other ancillary folks, respiratory therapists, pharmacists, others. But then our physician structure really rose to the occasion, and having a very large research hospital, being on the front lines of these clinical trials and helping to rapidly assess the efficacy of certain approaches, and watching our clinicians reach consensus about next steps given some of the uncertainty. Gosh, it was so gratifying, just so
Sure.
gratifying.
Let's shift a little bit to the payment model. Jim, I know you're a big proponent of moving to value-based payment models. Talk a little bit about what the pandemic may mean for that transformation. Obviously, we've adopted telehealth at a faster clip, but really, it's not like you've transformed the payment model in telehealth. You're moving care from one setting to another. I'm not necessarily sure that's value-based payment models, but where do you think the industry is going to go, and can it continue to adapt a payment model in the middle of a pandemic?
Well, I think it's inevitable that the payment model is going to change more rapidly. It's been changing more incrementally, but I think a couple of facts support this. Number one is the federal government and the deficit at the federal level has skyrocketed as this country has reached out to try to stabilize the economy. And so if there was ever any wiggle room in the federal budget, it is certainly gone now. And so we should expect that from CMS, there's going to be continued pressure on the Medicare program. Now, the ACA and Medicaid and all of that is a question mark. But again, I believe that this country is going to step up and say we have to have a coverage solution that is more systemic. But those will be federal-state partnerships that are also very price sensitive, because local voters in states like Texas, want to pay a fair tax, but not anything more than that. And then you have employers who, some have done exceedingly well, but even those who have done exceedingly well have said, hey, there's got to be a better way for us to pay for health care and to make sure that we're getting what we need and no more. So I think all of those roads lead to different payment models that provider systems are going to have to accept and are accepting in many creative ways. Sure, the push to outpatient has been with us for 30 years now, and that will continue. Maybe there is no physical dimension to healthcare in the future. Maybe it's largely a digital transaction. So it doesn't matter where you are. You can be on vacation, you could be at work, you can be in your home, and you're getting healthcare. And I think a value-based model would push more of those creative solutions to the fore. The role of the home in healthcare, and a lot of companies are now saying we're going to push healthcare into people's homes in some new and creative ways. We're not going to do heart transplants in people's homes, and we're not going to do heart transplants digitally. And so these hospitals that do transplants, we did 60 heart transplants during the last 7 months. And so those services don't stop. So I think it's going to be a continual adjustment, readjustment, learning process. But I think the direction of this is crystal clear.
It's interesting that you did that many heart transplants over that period of time. What do you see as the future for digital and telehealth for the industry, for Baylor Scott White? Obviously, we've pushed so much to that forefront, but we're also starting to see some payers not reimburse at the same level that they were at the beginning of the pandemic. So what do you think the future of telehealth is?
Well, it's a good question. And as long as the incentives are to bring people into a physical environment for care, then that's what a rational health system will do, is bring them in. DoorDash, Uber, Amazon have really proven that that's not what customers want.
Right.
Customers don't want to go to the store. I don't want to go down and pick up, dinner, I want the dinner delivered to me. And so this convenience push from customers is undeniable. It's inevitable, and directionally, it's going to happen. I think payers have to suit up in this, and we're a payer. We have a health plan, and we're looking for ways to create the right incentives for the change that will be better for those we serve.
That's great. And lastly, Jim, as we head into flu season and a potential second wave, as you reference, what kind of key lessons are you taking away from the first 6, 7 months of the pandemic as we head into flu season and beyond?
Well, it's fascinating, isn't it? I mean, you've read all the comparisons with all the previous flus in this country, and if you lay that side by side with what have been the most impactful changes in healthcare that have increased the lifespan of human beings on this planet, a lot of them have been public health in nature. A lot
Yeah.
of them have been around sanitation and clean water and and those types of things. So I think the lesson learned and the new lesson is to remember the old lesson, and that is if people wash their hands and if people will wear a mask and if we will appropriately distance and take advantage of some of the new testing methodologies that are out. And I think we can help ourselves, our families, our health systems get through what comes up with the flu. Now, people need to get a flu shot, just as they're going to need to get the COVID vaccine whenever it is widely available. But these viruses have been with us. They will continue to be with us. And I know this isn't a popular thing to say, but wearing a mask might be a part of the rest of our lives in some manner. And if what that does is protect our families and reduces the burden on a very expensive asset called our healthcare system, then I think that's a small price to pay. Not everyone would agree with what I just said.
Yeah, it's unfortunate that that's become so politicized over the pandemic, wearing a mask and social distancing. I did want to, lastly, I know I said that before, but this is the last one. On the vaccine, there is so much pressure for folks to get the vaccine. Obviously, we see healthcare systems requiring employees to get the flu shot. What do you think the industry is going to do in terms of vaccine and potentially requiring staff to get a COVID vaccine once one is out there?
Well, some of it will depend on the availability, the timing of the vaccine, and what the science says around the efficacy and safety of the vaccine. The annual flu shot is a pretty low risk proposition, but even with that, a lot of people still don't get a flu shot. So our system requires a flu shot unless you have a qualifying exemption, and I would imagine most hospitals and health systems have a similar approach. And I think that we will probably evolve that way as we know more about the vaccine, as I just mentioned. It's interesting. There's a lot of sociological and political and behavioral questions floating around out there. We can only control what we can control, and then try to influence and help shape a broader conversation on health policy in this country, and we will continue to do that.
Right. Well, Jim, thanks so much. It's always good to talk to you. I appreciate your insights. We'll be sure to check back in with you as some of these things unfold. But thank you for taking some time today.
Great. Thanks, Matt.
Thanks. And I'm Matthew Weinstock, Managing Editor for Modern Healthcare. Be sure to come back next Monday for another edition of The Checkup.